Welcome to the Living Medicine Podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show. This is Signe Goldman, your host today, and I'm talking to Michael Mithoefer, who most of my audience knows quite well or knows your work. But for those of you who don't know who Michael is, I will just say that many of you know that we are in this sort of second psychedelic renaissance, and certainly kind of like a big psychedelic renaissance into the awareness of psychedelics for mental health. And that is really changing the landscape for how people think about what mental health treatment will look like. And this paradigm shift that we're in now, rocky as it is right now, is really based on research. And Michael, and especially your collaboration with Rick Doblin, I think around 2000. So Michael was one of the lead people that put together the collaborative kind of studies with the FDA, the phase 2 clinical trials, early in, I think, 2000. And then after that, quite a few trials. So that research has really sort of opened up the conversation and was really instrumental in a lot of ways. But one of the other things that you do a lot of, along with your wife, Annie, who was on that research team with you, is teaching and training training therapists to do this work. So you're a trainer. And I'm a trainer. I train therapists. And part of how I learned how to train therapists is because you're one of the people who I also learned from. And I find myself in these conversations lately a lot about the non-directive approach. You're someone who has been often quoted as, in reference to that idea or that phrase. And so I thought I would kind of text you and see how you felt about talking about my concern that is so misunderstood. And so I really appreciate you coming on. Why don't we start by, do you have thoughts on that already before I reached out to you, on sort of that concept of the non-directive approach and how people are hearing that?
Yeah, I'm really delighted. Thanks for the introduction, Signe, and I'm glad you mentioned Annie because my wife Annie and I have done all these studies that we've worked on together. So, we're co-therapists. So it's kind of peculiar, even though I've been doing clinical research for 24 years now. I've been working on it. I'm not really a researcher. I'm a therapist. I'm a clinician. Annie's a clinician. And we were forced into doing research because we needed a better treatment for the patient. So for us, it's always been about therapy, and not about the drugs, but about tools that will catalyze people's ability to engage in therapy with connection to their own innate healing capacity. Mm-hmm. We originally learned that from Stanislav Grof, and his wife, Christina, because about 30 years ago, after 10 years of practicing emergency medicine, I was looking for a change in my career. It was reading Stan Grof's book that had was the main factor in my deciding to switch to psychiatry. And I did that training with the Grofs over 2.5 years while I was doing my psychiatry training. So I could see, and the Grof training was based on what Stan had learned studying LSD psychotherapy.
Yeah.
Many years before. He was one of the primary LSD researchers. And, he came from a tradition of academic biological psychiatry and Freudian psychology. And when he came upon LSD, that was sent around to universities by Sandoz, he was surprised. He didn't have this framework, but what he quickly realized, sitting with thousands of people in LSD sessions, that people kept having these unexpected experiences that tended to be very, very healing if they were handled well, if they were supported and integrated. And these were not coming from the Freudian theory or from doing anything else biological. And then I think a very important point is after many years of LSD research, when Richard Nixon suddenly made LSD illegal, and Stan Grof was at Johns Hopkins and at the Maryland Psychiatric Research Center, it was going to be a big deal. Researching psychedelics was a hot topic in psychiatry. And then it was shut down by Richard Nixon in 76. So, um, but what Stan then discovered is he realized that there were other ways of shifting consciousness in this way, that were some of them involved other drugs, ayahuasca, peyote, ibogaine. People have known about plant medicines that could shift consciousness like this for thousands of years, but also people have known about yoga and meditation and prolonged dancing and drumming and sun ceremonies, all these other ways, technologies for shifting consciousness that aren't even about drugs. So when we trained with Stan, he taught us to to do our own and to facilitate others in holotropic breath work,
Yeah.
which combine music and vigorous breathing in a therapeutic sentence, a supportive sentence setting. And people have remarkable shifts in consciousness, it's like they had with LSD or psilocybin or ketamine or MDMA. Not the same, but the same phenomenon.
Yes.
What Stan talks about, Stan Grof coined the term holotropic and holotropic as two general categories of consciousness. And holotropic, holotropic means oriented toward matter, which is important to be able to do. We spend a lot of our waking consciousness oriented toward matter so we don't drive off the road and things like that. However, what people have realized for thousands of years is there are ways to shift into what Stan calls a holotropic consciousness oriented toward wholeness, which has many benefits. So if you can have a way to intelligently and skillfully shift your consciousness to a holotropic state, it has benefits, healing benefits. And of course, in the ancient cultures and some contemporary cultures, those things go together. Shamanism involves healing, community life, and spiritual life. So they tended to go together, but there was a powerful healing potential. In a way, what Stan summarizes what this is all about is the healing potential of non-ordinary states of consciousness. And how you get there is secondary. Sometimes it's breath, sometimes it's dancing, and sometimes it's medicines that can be very useful. So that's that. I guess I don't want to go on too long, but I think that's an important point. It's not about the psychedelics. It's about the tool to shift consciousness. We happen to be using these psychedelic drugs, and that involves paying attention to the drug, obviously. Have to use them intelligently like we do every medicine, and they have to be regulated by FDA to be safe medically. And it's not mainly about that. It's about tools for the therapy. So, and you name the big problem we have. Once we mentioned, I mean, Stan talks about this concept of the inner healing intelligence.
Yeah.
He says when you go into a holotropic state, however you got there, LSD, MDMA, breathwork, ketamine, when that happens, he says it's as if there's an inner radar that scans for what is important for you. Experience is important for your healing and growth, and
Yes.
that experience. And the therapists have no way of knowing ahead of time what that experience is going to be. And the patients or the participants have no way of knowing. But one thing that we've seen again and again is it will happen if you don't interfere. So that's where the non-directive approach comes from. Is the main point is it's not that the therapists don't do anything. Many therapy skills that therapists have can be very, very helpful or even essential in these sessions. It's a matter of how you apply them and whether you're applying them with a preconceived agenda which is a problem in my mind because then you may get in the way of that unexpected experience that would come from the person's inner healing intelligence. That's the point.
So this idea of the non-directed approach is don't have an agenda and don't get in the way of the innate healing instinct that, the person in that altered state has. But it doesn't mean don't talk or don't engage. Is that?
Exactly. That is, as soon as we said non-directive approach 27 years ago, or Stan had been saying it before that, now we've been trying to explain what we mean by that ever since. And it's understandably confusing for people because it sounds like maybe you're not doing much.
Yeah. Well, I'm so glad you brought in that history with Stan Grof and all of that. A lot of people may not know that was when you started teaching and training, that was the background that you had, and that you already had that breath work training and that awareness of like, non-ordinary states more globally, right? And it's also good for people to know that one of the main psychedelic researchers out there, which is you that I'm talking about right now, you and Annie, and actually the rest of the MAPS team too, but you came out of holotropic breathwork backgrounds. So altered states achieved in other ways other than psychedelics was something that you already understood and had lived experience with. Who coined the term non-directive? Was that you? Was that Stan? Where did that term, sort of the non-directive approach, come from? I know it's kind of it's an extension of this idea of the innate healing intelligence, but
yeah, well, I'm not.
it's a mystery.
It certainly comes from Stan Grof's idea.
Yeah.
If Stan ever used those words, he basically talked about the inner healing intelligence, or sometimes the inner healer. I tend to use inner healing intelligence because I don't want to anthropomorphize it too much.
Mm-hmm.
Yeah, maybe that's the term I used in the beginning when I started writing down in the protocols what we were going to be doing in the therapy. I can't remember if it came from Stan's ideas anyway. And interesting.
So the term you used in the protocols initially was non-directive.
Yes.
What within the MAPS trials? Got it. Okay.
Yeah. And then we'd say relatively non-directive. But then Rick Doblin, interestingly, not only did Annie and I train with Stan Grof, but before that, and before we had met him, Rick Doblin, the founder of MAPS, had trained with Grof. So we never really talked about the therapeutic approach. We just went and did it, but we were all grounded in the same idea. So Rick had the same idea from Stan.
Yeah, I find myself in a parallel position, and because I'm training sort of the current generation of therapists that's coming into the ketamine assisted psychotherapy world. I'm one of many people doing that, but and so having to put words to what that is, because many of these people do not come from a holotropic breathwork background, so it's not intuitive. And I think I share with you the fact that I had a background in working with other forms of altered states, and I sort of I already knew that there was an inner healing intelligence, and that was the source of the solution for the client often. And I already sort of understood that the role was to stay not get in the way of that, and to sort of follow along with that. But I found myself, when I started running a training program, having to put words to it. And really, let's say, this is what this means, because people don't often understand. And so I love that it came from Stan, and that we get to kind of name him as I don't know, as like sort of a pioneer thought leader in this concept that we all carried forward of what we're calling the non-directive approach, and I use the phrase non-directive approach very much in trainings, but then I have to go on to explain a lot about what I mean by that, or demonstrate it, or things like that, is what I've found.
Yes.
So, I think we've landed at the non-directive approach, that phrase, because it gets thrown around a lot, but that phrase comes from the idea of respecting the inner healing intelligence. And that inner healing intelligence goes by other names, but people call it different things, but it really is the idea that on a psychedelic, or in any kind of altered state of consciousness, there is something that arises that doesn't come from the client's conscious, rational mind, and also doesn't come from the therapist. There's something that arises that is healing and that knows what to do. is kind of a way of describing this idea of the inner healing intelligence for those that just want us to, I want to make sure the audience is tracking along with us here. So
Yes.
if we all agree that that's happening, and I think anybody who has sat with anyone in altered states for any length of time cannot deny that that is what's happening. That is the most compelling thing about this work, is that there is an innate healing wisdom that sort of guides the client, that just shows up, right? So then the next piece is, we as therapists need to not get in the way of that. And that's where the idea, I'm imagine, of you using the phrase non-directive approach came from. And that is 1,000% the correct stance. And then now I think a lot of people are grappling with, they want to have a non-directive approach, but the misunderstanding I see out there the most, I don't know if this is what you have run into, is that means that you kind of sit mostly silently, like you don't talk to them unless they're in acute distress. I mean, you sort of, you're really holding space and letting them have a psychedelic journey on their own, maybe only stepping in if there's some sort of acute need, but you're not dialoguing. And then afterwards, when they come out of the medicine, then you integrate it. And so there's not a lot of verbal exchange happening at all. And so interestingly, a lot of these people have been through MAPS training, as have I. And I always, my reflection on watching you and Annie work, and because the MAPS training that I did was with you and Annie, and I know Bruce and Marcella also have, in the videos, that's not the case at all. I feel like, yes, there are long moments of silence when the person is in their journey, but there's also quite a bit of you dialoguing, you letting them know that you're present, you mirroring back the content that's showing up, reassuring, other kinds of things. But that's my memory of it. I just want to know if you have thoughts on that. Like how, I guess the confusion is that non-directive doesn't mean that you're not in dialogue.
Right. Yes, I think that's so important, Sydney. And I want to add, we've never been that happy with the non-directive term. And some years ago, it's been quite a while now, I was talking to Rick Doblin about this, and we were all discussing it. Rick said, how about inner-directed?
Mm,
So, and we now use inner-directed, I mean, it's directed from inside the participant.
that
So
is better, actually. Yeah.
better. But the main point is the same. Yeah, we certainly are in dialogue with people quite a bit. And of course, that's where there is a difference between medicines and doses. MDMA is more relational and more conversation, sort of like psycholytic doses of ketamine or even other things. But the point, I think, it's not a point of, do you engage, or do you even use, sometimes elements of other therapies that we've
Right.
experience in will be very useful in service of what's happening. But that's the point. So it's not that you never have conversations or never give guidance or you never give direction. There are three criteria, basically. One, is it needed?
Mm-hmm.
Often it's not needed. So yeah, shut up and sit there. If something is,
Yeah.
be present, be empathic, but don't keep your yapper shut if something is needed. So there's that, because sometimes we can, as therapists, we can either consciously or unconsciously begin to feel we should be doing something useful.
Yeah. Is it you that coined WAIT, WAIT? Why am I talking?
Dick Schwartz did that.
That was Dick Schwartz. Okay, I couldn't remember, but that's a good example of that. Okay, keep going. So there's needed.
Yeah, why am I talking? So yeah, A is needed. Don't say it because you think you need to sound smart or useful, or you're getting bored or something. Or you're getting anxious about the person's experience because it's triggering something in you and you want to interrupt it.
Yeah.
Be aware of those things and wait and ask yourself, why am I talking? But then sometimes there is a good reason for it. And then the question is, have you given ample timing and encouragement for it to keep unfolding on its own?
Mm-hmm.
So, for instance, somebody might be feeling really stuck and blah. And sometimes eventually we end up talking about that more and exploring it. And
Yeah.
it's similar to other therapy. But first, we're apt to say, I think this might be a good time to go back inside with that feeling and see what comes.
And those are things you are saying on the medicine.
Yes, on the
And if you do end up exploring it, you're exploring it on the medicine in this example you're referencing.
medicine. Yeah.
Yeah. I'm emphasizing that only because I think a lot of people think, oh, you just sit there and then afterwards you talk about it in integration. And you do, but that's not the same thing that you're referring to here.
Yeah. Good point, Sydney. Yeah. It is true that the preparation and the integration sessions there's more talking and they're more directive, maybe. I mean, there's a lot of the same spirit, but the integration sessions, yes, you do tend to talk about it more. But yes, we're talking about the medicine sessions. And yes, you may end up exploring it in the medicine session if you've given ample, something is necessary. I mean, often it's just unfolding and nothing's necessary. Then if stuck, have you given ample time and encouragement for it to unstick on its own, which often happens if you invite somebody to go inside, or it might happen if you say, what are you noticing in your body with that?
Yes. Yeah.
You work a little bit with what's happening in the body and it will release. So we like to try other less directive ways of inviting access to their own ability to get unstuck and can unfold the process without anything from outside. That's
Yep.
more accurate than anything we're going to do. So that's one. Is it necessary? Two, have you given ample time and encouragement to have it unfold on its own with a little suggestion? And then third, if both those conditions have been met and something is necessary, what's the spirit in which you offer something? You offer it as a possibility or a choice or even an encouragement, but never a directive.
Like an invitation.
Invitation.
They can take it or not.
Yes. And we tell people in the preparation session, and we may say it again right then, we don't want to push you into anything that isn't where you know better than we do about whether you're ready to go there. But would you be willing to go inside and with that question? Always emphasizing the choice, because there are a number of reasons for that. One is it's not going to work very well otherwise.
Mm-hmm.
But the other is we actually believe that they know better than we do on some level. There's some levels on which we may have really good suggestions, and we, in a way, we have more experience than they do, so we may have reason to think that something would be helpful. But there are also many factors that their inner protectors know about that we don't know about.
Yeah.
And
yeah.
so we want to honor that inner protection. And we don't, it may be that there's some block that would be helpful to remove at the right time, but there may be some reason why that's not the right time that we don't know about. So ultimately, we invite, we may even encourage, but we never push. So that's the third element. Are you offering it in a way that they can either accept it or reject it easily?
Right. And they feel comfortable either way, that they have permission to do that.
Yeah.
And have, so they're encouraged to be tracking what's trying to naturally unfold inside of them and honor what feels ready to happen. And also if there's some resistance to something, honoring that, like the client you're not getting ahead of that is what I hear you saying. And if you have an intervention to offer, you do offer it, but you offer it as a choice.
Exactly.
In a gentle way. Yeah.
And we use that term. We sometimes say, don't get ahead of the medicine.
Mm-hmm.
So in a way yes, they are tracking their experience, but there's a trap there too, because we invite people, you don't have to figure out what to do next.
Mm-hmm.
And let go and trust that your inner healing intelligence will show you.
Yes. And so often that shows up in the form of emotion or body sensation or something they don't even have a story for anyway. And you want to be able to track that. So I think to put this into language for the audience, and maybe you and I can toss this back and forth, maybe your language is something I'm interested in. Is it correct to say that you are in dialogue with the client enough to let them know that you're present with them and that they have that support, but you're not leading them or kind of telling them what to do in any way?
Yes.
And then when something is coming up for them, you are first encouraging, creating an encouraging environment for things that just spontaneously like unfold the way they are spontaneously unfolding. But if you feel like you have an intervention, a therapeutic intervention that would help with this, and your experience is that sometimes that's the case, then you will offer that, but you'll dialogue with the client around offering that in an invitational way and giving them they may take you up on it or they may not, but you encourage them to check in with their own inner healing intelligence around that as well. Like, would it feel right to do this or not? Some sort of, that kind of an idea when you're offering an intervention.
Yeah.
That fair? Okay. Is there anything I missed with that? Like, what else would you add to that?
Well, maybe how about a few examples? Maybe would help to
Hmm.
clear. So the first one about checking in with people, I think a good example is you might have seen the video. You probably have. A Marine veteran who was in his third MDMA session. He had two lower dose, 275 milligram, which were very powerful. And then he was in his first 125 milligram session. And there was a period of time when he was lying back on the futon, kind of propped up, looking straight, kind of up at the ceiling, talking about really, really painful things that had happened in Iraq and after Iraq. And it went on for a long time. And if somebody looked in the room, they might have thought he didn't even know we were there, because
Yeah.
he and I were sitting on either side. He's not talking to us. He's just processing out loud. And after a long time, we began to wonder, felt we should check in some way. So I think Annie asked him, "What are you noticing about the MDMA?" And he said, "It's allowing me to talk about things and remember, feel things in a way that I never had before." And Annie said, "Are you feeling connected to us?" And he said, "Yeah, yeah."
I
That's
love that example.
why I'm able to talk about these things. If I
Yeah.
feel connected to you, I don't think I'd be able to talk about these things. So
Okay.
that's that part.
I just want to riff on that for a second because I love that example because it brings up two things that I think are often misunderstood. One is Annie is doing a check-in there. I call that a tracking prompt, check-in prompt. She's saying she's checking in with him if you haven't dialogued with him for a while.
Right.
And like, I will just give a frame of reference that I teach a lot of people that work with ketamine, and those sessions are shorter. MDMA sessions are a lot longer. That is relevant for how much you're checking in or how much silence you're sitting in some kind of practical ways that we won't get into today. But there are also, for the purposes of honoring the inner healing intelligence and the non-directive approach, all the teachings are the same. And one thing that I often find myself really encouraging people to do is just those check-ins periodically, because I have learned that when someone is on the medicine, they don't find it disruptive to be checked in. They actually find it reassuring that the therapist or therapist team is tracking them. And even like you said, they may not be overtly naming that they feel accompanied, but if they feel accompanied by you as a therapist, it makes a huge difference in this relational way. And I also love that she sort of checked in on what some people think of as transference, but she checked in on how he was feeling about the relationship with you guys in the room.
Yeah.
And there's often a lot there. There's a lot of their sense of being held and tethered to you while they're in the altered state is actually what creates a lot of the safety for them sometimes to go to more challenging places, but it also can create a lot of the healing, the relational healing, if if they have relational trauma. And so, I one of the I mean, I guess I'll just use the word mistakes, but one of the mistakes that I see a lot of like people out there in the CAP world, the ketamine assisted psychotherapy world, is they're dosing people, frankly, a little too high. They're dosing them so high that they can't really dialogue. But regardless of that, they're not checking in with them or giving them any kind of verbal or touch or any kind of cues to let them know that they're still there. So the client just goes out in outer space and they don't have it, they don't know have any way of knowing that the therapist is still present with them unless the therapist is letting them know that. And so they feel they get more afraid or they feel alone or they feel like, they were just out there on their own. And I think that there's a loss of a lot of like therapeutic potential there when you just let the client go off on their own. There's zero dialogue and you're just sort of sitting in the room and they don't know you're still there. So, uh, so that's me talking a lot, but it's something I keep seeing. And I am often telling people lower the dose enough so that you can dialogue with them enough in a way that's non-directive, not interfering, and you certainly don't just talk at them the whole time. That goes without saying. But that they know you're present and that you're tracking and that whatever's happening, you're present for it. That's a huge part of it. I'm gonna stop talking for a second, but
No, I'm glad you're talking about that. Yeah, I agree. I mean, as Bessel van der Kolk says, healing happens in relationship. Human beings heal in relationship. Um, so yeah, it's and yeah, that really good point. You don't have to be so afraid of interrupting their process. Another video I think you've seen is I think the person who talked the least in all of our MDMA sessions, it was another veteran who basically he only talked when we checked in with him every hour.
mm-hmm.
He said things like, um, when I ask myself, should I talk about any of this? My body says, no, let's just keep going deeper.
Yeah,
So he would say things like that to us when we checked in, and it was a nice little connection. And then he'd go back in. We didn't know anything about what had happened until he read it to us the next day. And there's another example of why it seems like a really good thing that we didn't get in the way with an agenda.
correct. That's like you knew when to let him be in silence, but you checked in with him and he communicated that.
Yeah, we had to.
It didn't pull him out of it. He was able to stay with it. Yeah.
And there was important information we needed because just like with the guy that we just talked about, sometimes often when people are inside and not talking, some people talk to distract themselves. And when they're inside, that's great. That's like gold. But it could be that they're inside suffering in silence, isolating and suffering.
Yes. This is what I think keeps happening. And I hear these stories. People come to our clinic or even our training program and will say that happened to them in other settings where they were like desperately needing some sort of reassurance or some sort of input that like things were going okay or some sort of knowing they weren't alone.
Yeah.
And they felt abandoned because the therapist didn't say anything at all or didn't. And a lot of people also weren't using touch, but that's we'll have a different podcast on that one. But regardless, there's no, so I think that especially if you have relational trauma or you have wounding patterns around relationship or abandonment or any of that, then you can accidentally re-traumatize someone by abandoning them in the session.
Yes, absolutely. And I guess I just realized I have another rule of threes that
Okay, let's do it.
about this. There are three things you need to know when you check in, because this guy that we talked about, who only talked every hour, somehow gave us all these three things without knowing that's what we needed. But what we needed to know was, are they having an important process? Because sometimes people might just be in there waiting for something to happen or
Yeah.
yeah.
Or
So
like thinking, I wonder what time it is. Are they going to ask me anything anytime soon?
and what he said at one point I mean, we didn't ask him that, but he said there's a lot
Yeah.
going on. So we knew there was a lot happening. And the second thing we needed to know, and are they handling it okay?
Uh-huh.
And he said it's beautiful. The music fits perfectly. So he was handling it well. Um, and is there is he handling it well? Um, what's the third thing? Um, well, I'll think of the third maybe later. I had a third thing that I usually talk about in the training about that. Um,
Well,
oh,
it's
is
okay.
he feeling connected to us? That's the third thing. Yeah.
I was actually going to say that. That's funny. Yeah.
And he said thank you for at one point he just said thank you for being here with me, something like that. So we knew all those three things. So you do need to know that. You don't want him to be suffering in silence. You don't want him to be not having an experience or blocked. And you don't want him to be overwhelmed and not handling it without you knowing about it. But if
Yes.
you know those three things, and the part about something going on also means it's moving.
Yes.
It was clear that it was moving. So in which case, then there is nothing more needed from us. Um,
Yes, I think that's beautiful. So I'm going to reiterate that in a minute for the audience. And um, one clarifying question for those that don't know, how long is an MDMA session typically?
well, our sessions are 8 hours altogether. If we're just kind of getting organized and talking and waiting for them to
Right.
come on. So the strong MDMA effect, I would say, is usually 3 to 5 hours.
So in a 3 to 5 hour session, it sounds like you had a policy of checking in once an hour if they were in silence, even though I know that wasn't necessarily typical. Why? And I think it's what you just said, but why just, is it because you needed to make sure, one, that there was an important process happening, two, that they were handling it okay, and that they knew you were present? They felt the sort of relational presence of you there accompanying them on the
Yeah,
journey. Yeah. Okay.
exactly.
I think that's lovely. Like we teach that same concept, which is to do a check-in periodically if there's a certain stretch of silence. The if the time frame is shorter because these sessions are shorter.
Yeah.
Um, but I think that the concept is really similar. And when we early on in this, we would interview people afterwards, about their experience, especially trainees coming through and doing their own experiential sessions. We process a lot, like in a teaching way. What was it like for you? And a lot of these conversations. Always the person will say that when they are checked in on, when they have been silent and then they're checked in on, they never feel it as interruptive. It doesn't pull them out of the process. They feel it as supportive.
Yeah.
And the reason is because we're not checking in telling them to do something. We're just checking in, letting them know we're present, and letting them know that they can share whatever's happening, or they cannot. And if they do share it, we're happy to mirror it back and just be present for it with them. So
Yeah.
that it's not, and to the extent that we are dialoguing around the content, we're either mirroring it back just to kind of let them know that we're hearing it and we're tracking it, or we're kind of what we call deepening prompts, which is really what else are you noticing, or what else is present, maybe in the body or maybe in the mind, but never introducing any ideas out of our own agenda.
Mhm.
So there's a lot we've just said here. One is, I think I would like the audience to hear, like, don't sit in silence for an entire session and then talk about it afterwards. Check in periodically. I mean, it's just a really great, like, nuts and bolts piece there. And when you do check in, your intention is these three things that you, Michael, have just named. Like, is there something important? Is there a process happening that's therapeutic or valuable? If not, then we could talk about what you would do if not. And then if there is, then make sure they're okay and that they don't need any extra support. And then thirdly, let them know in a relational way that you're still present and you're still tracking them. You're not on your phone reading your email and zoned out. You're fully present with them. And that's a huge part of what creates the healing container for them to stay in the process. Right.
I think so. Yeah. I mean, I know some people that say they can read and then be when somebody's inside and be present. But for me, it's a practice to not check email, not read, not do anything, but do my best to be present. with that person. Sometimes my mind wanders, of course, and then I try to gently bring
Yeah.
it back. So to me, there's great power in the fact that you're present in between the times you're interacting. And so when they come out, you're right there.
And I think one of the humps that a lot of very new practitioners need to get into is just the being a verbal check-in, because they're intimidated, or they feel like they just want to sit, and they miss that opportunity to stay to create that connection and to reassure the client of the connection. It's just checking in. How are you doing? Okay, then that's it. I mean, or what are you noticing? Which is what that example you gave with Annie. Just doing that quick, checking in, letting you know I'm here kind of idea, and that anything that's happening is okay. And do you want to share it? And if you share it, we can, and sometimes people do share it, and then you can work with it. And then this is another point you raised earlier. Then you can work with that whatever process they're in, using therapy techniques that you have, as long as you've been through a training enough to know which ones are appropriate and how to do that appropriately. But you can actually do therapy while someone's on the medicine.
Absolutely. Sometimes
Yeah.
that can be very helpful to give somebody some direction if they're really stuck. If you're using it in service of what's trying to happen, rather than in service of your agenda that you think this person needs to have, prolonged
Yeah.
exposure therapy or internal family systems therapy or psychodynamic therapy, whatever. Um, Once something starts to happen, maybe what your training and experience in one of those things could be a very useful tool to help somebody kind of get unstuck in the process.
Mm-hmm. And I know I keep saying this, but on the medicine we're talking about, while
Yeah.
still on the medicine. I keep saying that because, again, I think a lot of people go, oh, that's the stuff you do in integration. Yes. And it's I think it's fascinating to me that I really think this comes from some lack of awareness or education on this, but also some intimidation people feel when they're new
Sure.
about, how and how much to step in. And that's something that you just sort of have to learn by doing. But we do, at least in our training program, we do a lot of mentoring and prompt and modeling of that. We show them videos, and we do a lot of, because my belief is that if you don't do that, you're really failing. Like, I know we've said this quite a few times, but failing to hold the relational safety of the experience.
Yeah.
And you know,
Something that's not helpful, and then you can have a repair with the person.
hmm Yeah, I have a teacher once who just, this comes from Hakomi, I think, actually. It's this really simple, like, you offer, the sort of offered intervention, like as an experiment. That's a Hakomi language for it. Like, we could experiment with trying this or this. What do you think? And you're saying this to the client, or you kind of offer a prompt that doesn't match. And then if you can tell by their body language that that's just not it, then, the teaching was just to say, okay, that's not it. And then just keep, like, it doesn't have to be a big deal, because, and it is true that when someone's on an altered state, in my experience, they roll with that. It
Yeah.
does That doesn't land, it doesn't interrupt them or derail them or anything like that. They always say afterwards that they really appreciate, um, just the connection attempts, the dialoguing that,
Yeah.
so, hmm.
Well, it's kind of, as Dick Schwartz talks a lot about this, it's great for the therapist to realize you don't have to know the answer.
Yeah.
You can try it and see, or you can ask, just ask. And if it's not right, just say, oh, sorry, that's not it. You know, you don't have to like get out of this idea, I got to have us all figured out for this person.
Yeah, I love that. It's almost like a mutual collaboration
Yeah.
between you and the patient or client's inner healing intelligence, with you just following along, but offering, like, is it this or this, or is it, or, touch is a good example of this. There's often, like, check in, at least the way we do it, like check in with what's happening, which is the way of saying check in with your own inner healing intelligence, and check in and see if what it would feel like if I put my hand here or whatever, and you prompt them to actually go in and check, and then they will know. They'll say, yes, actually, that
Yeah.
would be supportive, that would help, or no, it's not quite that, right?
Yeah.
So if you give the client the permission to and the sort of acknowledgement that they have the ability to check in with that and really authentically say what they're what feels like it's unfolding and what feels right or supportive, then yeah, you're really following along and asking them,
Yeah.
but you're still using your skill sets, just not, not in the same way you would in ordinary therapy. But like one example of that you already mentioned is you mentioned Dick Schwartz. So parts work shows up a lot.
Hmm.
So you can use your therapist skills with working with parts, not the same way you would in ordinary awareness, maybe, but it help, you can you can go there. Um, when someone's going through something really traumatic, you can move into like working with that. If someone's having some really somatic experience, you can do somatic interventions.
Yeah.
And and this is on the medicine. I know I keep saying that. So.
Yes. Yeah, I mean, I'm trained and I used to be certified in internal family systems therapy, and I find that extremely useful in this work. And sometimes it never comes up,
Yeah.
but often, we do have one little pilot that we haven't published showing that on active doses of MDMA, people start talking about parts a lot more often, like set
Yeah.
almost 80% of the time.
We actually did an interview with Dick Schwartz and he mentioned that.
Oh,
He mentioned that you had told him about that.
good. Cool.
He was really intrigued by that with this, yeah,
So
with
it
the idea of working with psychedelics, yeah.
So but the majority of the time, thinking about it in terms of the IFS principles that I learned from Dick and others is very helpful for me to sort of track one way of thinking about what's happening, which is what it is. But sometimes, if they're stuck or something, I end up doing what could, rarely, but it does happen sometimes in the medicine sessions. There's a little section that could look like an internal family systems therapy session.
Yes.
If the person was, really in that and it wasn't shifting and they needed some more interaction, then it could look like IFS. Most of the time, it's more like IFS informed
Yeah.
for me. And sometimes the principles come in really handy because, one thing that we've noticed watching many, many hours of videos, it's been great because we got to train the MAPS therapists and then we got to watch them work on the videos and then give them consultation about it.
Mhm.
Um, and, what we saw was we had a really great bunch of therapists and I mean, they did very well in general, but when they weren't adhering to the inner-directed approach so much would be either when they, would say, well, I'm like, that person was kind of reaching out and asking you for more direction. How come you didn't respond? And they would say, well, we were trusting the medicine and the inner healer. And I'm like, great, but don't trust it that much. You're there for a reason.
Yeah, you are there for a reason. Otherwise, they could be on quick.
But the other side is they were all really good therapists that had a lot of good training. And if they started being what I would call directive in a way that wasn't consistent with my idea of the inner-directed approach, they would do something useful. It would be helpful, but they don't know what they would have been missing.
Hmm.
Like that guy that we only checked in with every hour, the experience he read us the next day that he wrote down was he had this whole experience of his friend who died who he couldn't save,
Hmm.
their spirit get up and forgive him and hug him and help him forgive himself. It was a whole mystical, transpersonal, deeply healing mystical experience that went on over time that he didn't even have time to tell us about at the time. So if we'd decided he needed to be doing imaginal exposure of some kind,
Right.
it would never have happened.
Right. You would have just completely derailed him
Right,
or created a jarring kind of
right,
experience for him.
right.
Right. That's the balance, I think, and that And there's an art to that, but it also can be taught. And I think step one is do check in. We've covered that. But if you don't check in, then you don't even know to what degree you like you don't even have a map for what's going on with the person at all. They're just in some sort of silent experience that might not even they may not be fully okay, or they may need a relational check-in and you just wouldn't know.
Mhm.
And when you do check in, give them permission to shrug it off if they're in a place like you've named. Like, an example of that from my experience would be someone saying when you check in with them, they say, "Oh, I'm good. I'm talking to my grandfather."
Yeah.
Then you would say, okay, like you would just let them be in that. Talking to your grandfather, just be in that. Yeah. You know, you don't need to analyze that in that moment. You don't need to ask them questions about it, that they're in it. Right. But a lot of times when you check in with people, they have something going on that they want to either, they want to hear reflected back. Even if you don't analyze it, they just want it to hear it reflected back, to know that it's been witnessed in some way or that they're being tracked. And then that's sometimes that's enough. And other times people are actually in a process where some sort of therapeutic intervention would be helpful or valuable. And then you do that. But you wouldn't know if you don't check in. Some people are very verbal and verbalize the whole time, and they'll just cue you right to everything, but a lot of people don't. And in the ketamine world, a lot of therapists are dosing too high. So the person is in the stratosphere. They're not even aware of, they're in ego dissolution state. They're not going to dialogue about anything. Um,
Yeah.
so that's kind of a practical piece.
Yeah. Well, and there's one, I think that's a beautiful summary. Yeah. In one way, it's not very complicated. Check in. Yeah. But there's an intermediate. So yeah, see if something's needed. If something seems to be needed, is there a possibility of, like, I'd say, well, to keep it simple, if something seems to be needed and something's a little stuck, encourage them to go back inside for a while.
Mm-hmm.
This is oversimplified, of course, but encourage them to go. This wouldn't be a bad way to just go. Encourage them to go back inside for a while, if they maybe, and see what they discover. That's usually the invitation. And
Yes.
often, then that'll do it. If sometimes they won't stay inside for more than a couple seconds, and you try it repeatedly, it's not happening, or they're inside for quite a while and it's still the same place.
So to
Then,
put some language to that for listeners, I mean, at least I think the way I often see that show up is you check in with someone and they may say, I'm stuck on this, or this is happening and I don't like it, or, they name something. And I think my version of what I'm hearing you say is to mirror that back. Oh, you're stuck in this and such, literally the same language, or this is noticing you don't like it. Check in and see what else is, let's just take a second to check in and see what else you can notice about that. I'm right here with you. I'll be here with you. I'll check it. Let's just go in and see what else is there,
yeah,
or and then that's sort of a way of prompting that. If I to put actual language on it,
yeah,
something like that, and then obviously you're tracking their body language. You're staying in touch to see if they're really they're struggling, and then you can check in again and be like, where are you now, or what are you noticing?
yeah. And
But
then,
those basic little things I just said there's a lot of people not doing any of that because they're not trained to do it. That is a real issue, but they haven't been encouraged to get comfortable doing it is the thing I also see.
yeah. And if
Sorry.
it doesn't work, then if it's still in the same place, I'd say, what are you noticing in your body when you're experiencing that? And then would you be willing to just stay with that body thing? Or does your body want to move or express it in any way? Are there any sounds that want to come? Try to not get too up in the head and see if something will happen with the body. So I would say in vast majority of cases, you want to do those two things in that order. So
Mm-hmm.
it's not working, check with the body. Not working, then that's when you're beginning to think about some of your therapy skills and exploring it,
Mm-hmm.
talking about it a little more. Um, with
Yeah, one of this brings up something which is a slightly different topic, but it is related in a way, which is that a lot of people coming in getting trained to do ketamine-assisted psychotherapy through our training program, and I believe all the others, are coming from all different kinds of training backgrounds, and some of them don't have somatic psychotherapy skills at all, so they're not used to cueing the client to track their somatic sensations. And they're also not don't have a lot of experience with working with that or use. So that's one of the things we're often encouraging people to do is to get more, at least to get an adequate amount of somatic ways of working with the body so that they're not completely at a loss when they do need to move to working with the body. Even if you're not a somatic therapist per se, you can adopt enough of those skills to be able to use that with people, and you kind of need to,
yes,
because this is another piece is where you can accidentally abandon someone is when what they're re-experiencing is very much happening in the body and they don't even really have a story for it, but it could be a pre-verbal trauma, it could be a lot of things, but their body is processing it out and needs to be met, or that needs to be allowed to happen. And that's another thing where I think that if you don't meet that adequately, that can cause, a sort of counter therapeutic experience.
I agree. Yeah, yeah, that's really important, Sydney. And we got retrained in holotropic breath work, which has a lot of body work that's actually kind of more dramatic than other things. Marcela and Bruce have trained in Hakomi and somatic experiencing.
Hmm.
And he's trained in Hakomi. So all of those things are
Yeah.
good ways of approaching. Or Pat Ogden's one psychomotor psychotherapy.
Psychomotor. Yeah. Yeah. I use a lot of Hakomi in my training program, Hakomi influenced work, because it, I feel like it's a really great fit because the Hakomi model is so much about letting the client know when they're in even with eyes closed and in mindfulness, that you are tracking them.
Yeah,
And it also has this really appreciation for how content can show up in the body as well as, the thoughts or emotion or story and so on. So, um, not everyone knows what Hakomi is, but if you're not a Hakomi therapist, the take home is some sort of somatic skill set is important and some comfort level with getting used to using it when you need to. Because I guess this is a little bit of a soapbox moment, and you'll have to forgive me, but I feel there is a responsibility we have to these clients. It's a huge responsibility because we're putting them in a vulnerable, position being on these medicines with us in a relational context.
yes,
And if you do not make sure that you have these kinds of skills that Michael, you and I are talking about here, you can find yourself in a place where you kind of can accidentally do harm, even if it's in subtle ways. Because a person's processing trauma, or things are, working through a process, and it needs to be met either somatically or what we were referencing earlier, it needs to be met relationally. And if those things don't happen, it actually just recapitulates the original wounding. And that what I've seen this a lot, which is why I'm a little on this soapbox. The client doesn't necessarily have the words to describe that. They don't even really rationally know that that's what happened. So they're not going to show up next day in integration and say, "Hey, you should have done this," because they don't know that. But that's when you have people doing this work that maybe don't have those skills. And I would kind of like to have this piece of education out there for that situation.
yeah,
And I know you come from a world where you really have to have a lot of training and oversight to use MDMA, but that's not the case with ketamine. So there's a lot of people using ketamine in a lot of different ways right now. And because I have a training program and I have some visibility for Sandy and I, one of the roles that we find ourselves in is cautioning people against being too cavalier and just assuming that they can just do what they're doing and that it's fine.
yeah, yeah.
So,
So important, Sydney. It's these are not trivial experiences. And I think one of the problems is, you know, some people do fine just taking these medicines on their own.
mhm.
And so they get the idea that it's pretty simple.
Yeah.
And I think it's, well, another rule of threes, maybe. Here's my opinion is because people are always saying, how come you're not doing any studies where you just put somebody in a room with MDMA and leave them alone?
Hmm.
Uh, and the reason is because we already know too much about MDMA and too much about PTSD to think that would be a good idea. But I do think that, on a rough guess, probably the third of the people would have a profound healing experience on their own. It does happen.
Right. It happens in recreational settings accidentally all the time.
Third of the people would probably have a pretty good experience, but it wouldn't be very helpful for them. And then a third of the people would be in real danger, and some would commit suicide.
Yeah.
That's the reality. These are not.
Yes. Thank you for saying that because this is not something to be played around with. It's not something to be taken lightly. And,
No.
I do supervision and mentoring. Sandy and Newis, my partner does this, my business partner does as well. And we often are doing mentoring, like career mentoring, or even like case supervision for new career ketamine therapists, either trained by us or trained in other places. And I've definitely had some conversations with people that are more like, that, oh gosh, it's tricky. I guess I'm often saying something like, yeah, what you're doing might be fine the first 10, 20, maybe even 30 times because a lot of people, like you just said, Michael, a lot of people can kind of roll and the experience itself will have healing content in it. And for the most part, they will feel like it was interesting, if not actually helpful. And you'll feel like, great, I've got this. This is actually kind of easy.
Yeah.
But then you're gonna get client number 39 or 40, and you're gonna do what you're doing and you're gonna harm them and you're gonna have this bad outcome.
Yeah.
Because what you're doing is actually you're just kind of winging it and you're relying on the fact that the medicine has its own innate healing ability to just assume that that's always going to happen.
Yeah.
And you're not taking responsibility for the role of the therapist as an active, you know, part of the process and as a responsible part. And I, like you said, a lot of times these medicines are just, you could leave someone alone and some of them would do great and
Yeah.
then some wouldn't. And if you don't know that and you can see your first 20 people and be like, oh, this is no big deal. And people get a little bit overconfident.
Yeah.
And then they also do this thing where they coast on the coattails of the inherent healing properties of the medicine without and just like let that do all the work and they just kind of don't do anything. Or and this is a little more concerning, they coast on the fact that the experience itself is impressive. Like being on a psychedelic, especially for a client who's never done it before, is an intense experience. And they sort of basically coast on the fact that they gave someone an intense experience. And that, as if that in itself is like the meaningful outcome.
Yeah.
And then, you know what I mean? So anyway,
Yeah, and then sometimes the therapist gets inflated by that too, and the patient can project it onto the therapist, thinking, "What an incredible therapist that I've had such an intense experience," and the therapist can start thinking that also, and then you can get into boundary problems and all of that. So,
yeah. Yeah. I just actually we just did an interview with Bill Richards the other day and we had a conversation about what I'm about to say now. So this is my second time saying this. It's just so true. My this doing this kind of work should not make you feel like you're a great therapist. Doing this kind of work in my experience is humbling. It's humbling because you are witnessing this thing that unfolds from the client's inner healing intelligence. You're witnessing that and you are present for it and you're responsible for being present for it in all these ways you and I are discussing today, but you're not making it happen. Like, so usually you come out like, whoa, I was witness to that. That was amazing. I didn't do that at all. So it was a privilege to be there. Um, and also like you are, I like this idea of midwifing it. Like the midwife doesn't give birth to the baby, but she has an important role.
Yeah.
You have to have the midwife there to be the person who's done it many, many times, has experience, can be reassuring, can step in with authority when needed, can encourage, and can just support the natural process.
Yeah.
And I think that's our role is we have to, but that doesn't mean we just like the midwife doesn't show up and just sit there and do absolutely nothing while the woman gives birth. You still have to show up and be, you have a role.
Yeah. And that's a great analogy too, because without the midwife, a lot of births would go okay too. But
Yes.
those ones that wouldn't, that makes
I
it,
want it. Yeah. And a lot of women would be a lot more scared.
yeah. Well, and luckily human beings have learned some skills to help each other not die in certain situations. And that's that kind of thing, you know.
Yeah.
Yeah.
Well, thank you for allowing that soapbox moment. I guess I am in ketamine world. There's is a little more of the Wild West right now, so I feel responsible for just putting out a note of caution around those kind of things. But really, um, we are mostly here today to sort of, you know, hear what we have just heard you say about the non-directive approach and the fact that it's non-directive approach is still an active therapy intervention.
Yeah.
It's just it's one of following and relationality and not steering or leading.
Yeah.
Is that fair? Okay.
Yes, it would be a lot simpler if you either just did nothing or you either did manualized prolonged exposure therapy or something. But it turns out it's not that simple.
Yeah. Well, I very much appreciate you having this conversation with me and jumping on short notice. There's a lot more that I would be happy to talk about, but I want to respect your time as well. So, are there any closing thoughts or things that you think that we should make sure to put out there while we have this opportunity before we close today?
Well, my main closing thought is how important this is to have education and good training for therapists working with psychedelics. I think it's so critical because, as you say, it can be deceptive, and it's pretty bizarre now. MDMA's slowed down over the therapy questions from the FDA, but meanwhile, of course, ketamine is approved as an anesthetic years ago. So all these people are doing work with this powerful psychedelic with absolutely no regulation or
Right.
oversight,
It's so ironic, right?
even training. So I'm so glad that you and others are stepping up to train people to use ketamine in a way that makes sense. So therapist training, and I think therapist self-experience in a legal
Mm.
therapeutic context with these medicines is also very important. You know, uh,
Yeah.
I, I think if I hadn't had my own experience with MDMA and other psychedelics, like it would be much harder to trust the inner healing process or have a feeling for the depth of the experience people can be having in front of you if you haven't had it yourself. So,
Oh, yeah. I agree so much. This is actually why we put the experiential part of our training first.
yeah,
Because when you give the experiential parts first, then when you go in and you teach ideas like the non-directive approach, people intuitively get it more. They're
right.
less confused. They go, oh yeah, I see why, they naturally kind of catch on because they've experienced being on the receiving end. Yeah, and I agree. It would be really so that's an interesting connection just to make is like the to this our topic today is the non-directive approach, but it is much more understood by a trainee who has experienced the medicine themselves.
Yeah.
Um, and so maybe a sort of public servant service announcement that we can jointly get behind is for training programs to overtly talk about this non-directive directive kind of confusion that people have and to teach the non-directive approach as maybe a person-centered approach or whatever it was that Rick said. What was it? The
Inner directed.
inner directed. So let's teach it as inner directed approach where, but you still are verbally dialoguing with the client and you are,
Medicine session.
what's that?
In the medicine session.
In the medicine session. Yes, thank you. Uh, And how do you do that is part of the responsibility of what a training program needs to address so that there's this misunderstanding out there. Okay, I have loved this conversation. I think it is so timely and so valuable from a safety point of view. And also it's just really interesting and fascinating. And also it is powerful because these are the tools that we use to in this work that also are make the, this is what makes this work so powerful and potent, is using these tools.
Yeah.
Right. And this is what, we are the collaborator with the client's inner healing intelligence.
Yeah.
And we need to know our role in that collaboration, which is that we're not in charge of it, but we are showing up in service of it. And this is what it looks like, is these things that you've described. So I love how you've given like these threes. So we have some actual like concrete bullet teachings here. And so I'm gonna put that in the summary below when we post this. Like, these are the 3 bullet points that Michael said for this and this and this, because I think my experience is trainees really are craving some sort of nuts and bolts, what to do. And that's super helpful for them. So thank you for doing this. I hope we get to talk more about other stuff in the future, like somatic. That conversation would be really fun to have. But thank you for your time today.
Yeah, well, thanks, Sidney. That was really fun, and to be continued.
Yeah, to be continued. Take care, Michael.
You too. Bye.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.